So we start with the first speaker. He is Dr. Ashish Markan.
Yeah, okay.
He'll be talking on predictive factors for structural and functional outcomes of 25 gauge PPP and removal of posterior intraocular foreign body.
A very good morning to all. So I'll be talking about the predictive factors for structural and functional outcomes in cases of 25G partial vitrectomy surgery for removal of posterior intraocular foreign bodies. So there have been a number of studies which have actually looked at these predictive factors. But if you go and study these papers, the results are quite variable. Also, there are many factors such as the size of the intraocular foreign body, the removal of the route of extraction of these foreign bodies, and whether putting an encircling element actually helps or not. And there are many other factors which haven't been studied that extensively. So the whole idea was to actually conduct a retrospective study and to look at the predictive factors which could actually guide us to the structural as well as the functional outcomes. So it was a retrospective data analysis. All the necessary demographic details, the preoperative data and the intraoperative surgical details were noted. Also, we devised this classification and we divided the zone of impaction into zone 1, 2, and 3. Zone 1 was defined as where the intraocular foreign bodies were impacted within the macula. Zone 2 was whether the impaction was present outside the macula but posterior to the equator. And zone 3 was where the impaction was present anterior to the equator. All the surgeries were performed on constellation vitrectomy system, and lensectomy was performed in all the cases of traumatic cataract and in cases where intraocular foreign body size was more than 5 millimeters. Also, the primary intraocular lens implantation was not performed in any of the cases requiring lensectomy. And decision to put an encircling element, the route of intraocular foreign body removal, and the choice of intraocular tamponade was decided by the operating surgeon. The structural and the functional outcomes were studied at 1 year of follow-up, which included the best corrected visual acuity, the retina status, and the presence or absence of epiretinal membranes. The functional success was defined as BCVA better than 6/60 at 1 year of follow-up, and the anatomical success was defined as no retinal detachment involving the macular area at the time of last follow-up. Univariate analysis was applied to study the associations. Coming on to the results, so 39 patients were included with 37 males and 2 females, and the mean age of the study population was 30.5 years. Majority of the injuries were workplace related, followed by home and domestic accidents. So if we see, majority of the patients had a zone 1 injury, and we had about 66% of the foreign bodies which were impacted, and majority of them were impacted in zone 2 and zone 3. Most of them were metallic foreign body, and we performed most of the surgeries within 2 weeks. Also, about 59% patients had an encircling element being put. The associated retinal detachment and end-off was seen in 20 and 30% patients respectively. Lensectomy was performed in majority of the patients, and the foreign body was removed through limbal route. So we also divided the size of the foreign body as small or large, depending on less than 4 millimeters or more than 4 millimeters. So at end of 1 year, the mean BCVA improved significantly. The retina was attached in 82% of the patients, and epiretinal membrane formation happened in 23% of the patients. So now coming on to the most significant part, the association between the retinal attachment or detachment and these independent variables. So when we applied the univariate analysis, we found that none of these factors, that is the zone of the injury, zone of impaction, whether the foreign body was impacted or not, timing of the surgery, if there was an associated retinal detachment or end-off, if we performed lensectomy and removed the foreign body to the anterior route, or the size of the foreign body, did not have any impact on the structural outcomes, whether it was retinal attachment or detachment, or whether it was the formation of postoperative epiretinal membrane. But when we studied the association between the functional outcomes and these independent variables, what we found was that 3 factors, they were important. First was the impacted foreign body, second was the associated end-off, and third was the size of the foreign body. So if the foreign body was impacted, there was presence of a preoperative endophthalmitis, and the size of the foreign body was more than 4 millimeters. These 3 factors were associated with a poor visual outcome, that is less than 6/60. So just to conclude that the presence of intraocular foreign body, which is impacted, an associated endophthalmitis, and a large intraocular foreign body are associated with poor visual outcomes. And none of these independent variables had an association with the postoperative structural outcomes. Thank you.
What was the new data that you have got out of the study? If you do the ocular trauma scoring, these factors are already known.
So the whole, like at our center, it is always said that you have to put an encircling element, because there was this study by Dr. Azad, which came up in 2004 or 2005, where they said that you put an encircling element and the structural outcome is much better. But that study was done during the age of 20 gauge vitrectomies. So what we found that putting an encircling element actually does not help. Second, apart from that, when we were looking for other factors also, we decided to look at the structural and functional outcomes for other variables, where we found that the size actually matters and the endophthalmitis it matters. So it was just our own experience of our cases which we have done, and that is it.
You said about the impacted foreign body.
Yeah.
How does that actually independently influence the outcome? Can you give some reasons?
So, sir, basically, most of these impacted foreign bodies were in zone 2 or zone 3. Majority of them were in zone 2. So, we had to perform a large chorioretinectomy in some of these cases. And that could have actually led to maybe a formation of an epiretinal membrane or something which could have affected the visual outcomes.
Normally, the retinectomy with good barrage, and normally that since it is away from the central fundus, it normally does not really influence the visual outcome, right? So, I mean, in that case, do you have any kind of cases in which the impacted foreign body has resulted in ARM?
Ye-
Foreign body which was free and easily picked up. There was
We didn't actually look at separately at the effect of impacted foreign body with an epiretinal membrane, but when we looked at it, though epiretinal membrane was not coming significant, the formation, but it had an impact on the, maybe because the size of the foreign body was very large, or maybe it affected the zone 1, that could have led to a poor visual outcome. We are not clear about that.
Regarding your lancectomy, how many cases you have done in the first sitting, or how many cases you have done
So
in the
about
second sitting?
80% of the patients, they underwent lancectomy in the primary sitting only.
Why? Because sometimes cataract develops a very long time to
No,
develop.
but 70% of them initially had a cataract. So
In your study, right?
in our study,
But
yeah.
that's not that common, because most of the cases, sometimes they develop cataract very later.
because about 60% of them had a zone 1 injury, and if it is a zone 1 injury, we expect that cataract would be present because it is passing through the cornea and going behind in the posterior segment. And
Okay, fine. Did you do any clear lens extraction as well?
no, clear lens extraction was not done. I think in 1 or 2 cases where the size of the foreign body was roughly 15 or 16 millimeters. There were 1 or 2 cases. In those cases, we had to do because we planned to remove it from the anterior root, the limbus.
Okay.
Did you do a pre-operative trauma scoring?
No,
See, that is where if you have a pre-operative trauma score which predicts a poor outcome, and then you can predict which of your factors were in contraindication or different from what the trauma score predicted.
This has almost same features. Or presence of foreign body, presence of endophthalmitis, they're all already there in the
Trauma scoring.
okay. Thank you.
Thank you.